The following podcast is part of a certified educational activity titled Dialing Up Precision in HR-positive, HER2-negative metastatic breast cancer with New Endocrine Agents, Targeted Therapies, and Combinations, a framework for multifactorial clinical decisions. Access the entire activity and complete the post-test at peerview.com/NXT860. Downloadable slides and practice aids are also available.
Welcome, everyone. Good evening. Thank you so much for joining us today here live, and also to our virtual audience for dialing in as well for this PeerView event. We are talking about dialing up precision in hormone receptor positive, HER2 negative metastatic breast cancer with new endocrine agents, targeted therapies, and combinations, a framework for multifactorial clinical decisions. I am truly honored and truly delighted to have been joined by this lovely faculty, these lovely friends and colleagues from around the globe. We have Professor Erica Mayer, who's the Director of the Breast Cancer Clinical Research at the Dana-Farber Cancer Institute. We have Professor Giuseppe Carigliano, a Professor of Medical Oncology at the Department of Oncology at University of Milano, and Clinical Director of the Early Drug Development. And then we have Professor Nicholas Turner, who's joining us from the Royal Marsden in London as well, and serves as the head of the Ralph Lauren Center for Breast Cancer Research there. So thank you all for joining today. Really also thankful for our advocacy partner, patient advocacy partner, which is Living Beyond Breast Cancer. What is Living Beyond Breast Cancer? It really provides trusted information, and it's a community of support to all patients with breast cancer. You're welcome to download the supplemental resource made available as part of this activity and learn how you and your patients can access support through Living Beyond Breast Cancer. So what are the goals for today's discussion? During the presentations today, we will learn why it is important to recognize the varied clinical spectrum and the different patient subpopulations within the hormone receptor positive metastatic breast cancer subtype. We will discuss how novel endocrine agents, targeted therapies, and combinations are changing and reshaping our standard of care for advanced hormone receptor positive breast cancer. Why nuanced use of biomarker testing is really essential to guide therapy decisions throughout the disease continuum. And ultimately talk about how do we select, sequence, and safely deliver the current and emerging agents and combinations in different lines of therapy. So breaking the one-size-fits-all mold, I think this is what we're really going to try and focus on in the first section, how to make patient-centric, multifactorial clinical decisions in hormone receptor-positive, HER2-negative metastatic breast cancer. Now, when we think about what is currently available to us in clinic for our patients, these are the FDA-approved therapies and the current treatment algorithm. In the first-line metastatic setting, majority of our patients do receive a CDK4/6 inhibitor with their aromatase inhibitor. These are typically, when we think about these patients, we're thinking about endocrine-sensitive breast cancer. This could be a de novo metastatic patient or somebody who's had a disease-free interval or a treatment-free interval of more than 12 months from the adjuvant setting. For the endocrine-resistant patient population, if the tumors harbor a PIK3CA mutation, we now have a triplet of inavolisib plus palbociclib and fulvestrant available as well. And then upon progression on the first-line therapy, we are making these treatment decisions based on biomarkers currently in clinic. For instance, if we have an ESR1 mutant tumor, we now have 2 oral SERDs available for these patients, elacestrant, and more recently, as of September 25th of this year, imlunestrant. For PIK3CA AKT-P10 alterations, we have capivasertib with fulvestrant. Alpelisib was approved based on PIK3CA mutations. We have PARP inhibitors for germline BRCA carriers. And certainly, for those patients where we don't have any other biomarker or what we call as wild type, we could consider either endocrine monotherapy, although we're shying away from that a whole lot, and we'll hear today why. Or we can consider using everolimus with fulvestrant or abemaciclib with fulvestrant based on the data sets that we have from post-monarch, for instance, with abemaciclib. So before we kick off, how to think about first-line strategies and how did we come to the standard of care and what's coming next, why don't we kick off with this case? This is the same case we'll think about as we think about the first line and beyond settings as well. So currently we have Helena, who presents with a newly diagnosed metastatic breast cancer. She had imaging, which was a CAT scan of the chest, abdomen, pelvis that confirmed a breast mass with numerous liver and bone metastases involving the spine, ribs, and hip. Breast and liver biopsy indicate ER positive, PR negative, and HER2 low by immunohistochemistry metastatic carcinoma consistent with stage 4 disease. She's asymptomatic. With respect to her comorbidities, she does have ventricular tachycardia, which is controlled on disopyramide. And her baseline EKG has a QTCF of 450 milliseconds. So she presents to your medical oncology clinic to discuss first-line treatment options. Now, introducing another case where we have Amy, who actually has received adjuvant endocrine therapy for hormone receptor-positive early breast cancer, but developed recurrence within 12 months of completion of adjuvant AI therapy. She presents with extensive visceral metastases. A biopsy shows ER/PR positive disease. HER2 is again HER2 low by immunohistochemistry staining. Pathology confirms metastatic disease consistent with breast primary. No germline BRCA1 or 2 mutations, and no other biomarker testing is conducted. Her BMI is 29. Hyperlipidemia is managed with diet, and she has no other known comorbidities. She presents to your medical oncology clinic to discuss first-line treatment options. So how would you think about treating this endocrine-resistant presentation for Amy? Okay, so to actually help us with these patients in clinic, why don't we have Professor Turner talk to us about first-line therapy options for endocrine-sensitive and resistant hormone receptor-positive disease.
Well, thanks, Kamal. It's a pleasure to be here to talk about first-line therapy options and some of the clinical trials that we've been doing in this setting to move things forwards. And of course, we're all familiar with the data, which is of course completely routine standard of care now for the use of CDK4/6 inhibitors in combination with endocrine therapy, where we've seen consistent benefit from all three CDK4/6 inhibitors when we think about PFS. We've also seen some really interesting long-term follow-up data, in particular with abemaciclib in Monarch 3, where we've now got follow-up up to 9 years on treatment. And you can see a clear separation of the curve and evidence that you're getting long-term durable response in a small number of people when you treat them with AI and abemaciclib, or very likely the other CDK4/6 inhibitors as well, suggesting that we're really changing the disease for a fraction of people when we treat them with an AI and CDK4/6 inhibitor in the first-line setting. For reasons I don't think we entirely understand, we've of course, despite that incredible consistency we see in PFS, not seen such consistency for overall survival, and that has of course gradually changed for many people what their preferred CDK4/6 inhibitor is when they're giving it in the first-line setting, with the clearest evidence for improvement in overall survival having been with ribociclib, but also with some evidence for abemaciclib, here again shown with long-term follow-up of Monarch 2, where you clearly see separation of the curves with abemaciclib as well as on the right with ribociclib, with durable separation of the curves, demonstrating this clear improvement in overall survival that we know we get when we give CDK4/6 inhibitor here in combination with fulvestrant. And so we've got many factors that we incorporate into how we treat patients with breast cancer, but actually relative consistency in the use of CDK4/6 inhibitors. We understand a lot more about how cancers become resistant to endocrine therapy and CDK4/6 inhibitors. We know of those that are having an AI and CDK4/6 inhibitor can acquire ESR1 estrogen receptor mutations. Around 40% of patients will acquire these mutations. We can see that the PI3 kinase AKT mTOR pathway commonly becomes overactive as a mechanism of resistance, and some also may remain sensitive to the CDK4/6 inhibitor if continued beyond progression. So the first study that we're going to go through is INAVO 120. So this was a study for people who are relapsing on adjuvant endocrine therapy, looking at how we can improve on palbociclib and fulvestrant, importantly in those patients that were PIK3CA mutated. And in this study, patients that also had measurable disease and had progressed during or within 12 months of completing their adjuvant endocrine therapy and were randomized between a standard of care, which is palbociclib and fulvestrant, and the addition of inavolisib. And of course, we saw really meaningful improvement in efficacy at the bottom with PFS, and also clear improvement in overall survival, which was statistically significant by adding in inavolisib, the PI3 kinase inhibitor, to PIK3CA mutant disease. But we learned, I think, a few other things from this study. We learned that actually the control arm did surprisingly poorly. So PIK3CA mutant disease that's relapsing on their adjuvant endocrine therapy does relatively poorly when treated with fulvestrant and palbociclib, substantially better when you add in inavolisib. And in the overall survival analysis, we saw that in the control arm, 10% of patients were dead, unfortunately, at 6 months. And so you might think, oh, maybe I'll give the doublet and I'll come in and target the PI3 kinase inhibitor later. But for these patients, it obviously wasn't possible to rescue them. And all of these factors have gone into this becoming a standard of care for patients in that first-line endocrine-resistant setting. But, of course, adding in a PI3 kinase inhibitor does bring some toxicity with it, with the characteristic side effects of PI3 kinase inhibitors of hyperglycemia, some stomatitis, and some diarrhea. But the second story, as we're now thinking and moving more towards the endocrine-sensitive indication of an AI and CDK4/6 inhibitor, is that these tumors can acquire mutations in the estrogen receptor that make them intrinsically resistant to aromatase inhibitors, and they get acquired in around 40% of patients who are treated with an AI and CDK4/6 inhibitor. The very best way of identifying these mutations is liquid biopsies, and this is now filtered through to guidelines that the preferred way of testing for ESR1 mutations is the liquid biopsy. And this is partly because these mutations can be heterogeneous, and if you biopsy a single-sided metastasis, you might end up missing the ESR1 mutation that's there in other sites of metastasis. We've, of course, got SERDs that you can use to treat ESR1 mutant disease at progression, and we'll look at this data later on this evening. But SERENA-6 was looking at an entirely different paradigm, which was doing regular liquid biopsy blood tests to try and identify those patients who were acquiring ESR1 mutations during their first-line AI and CDK4/6 inhibitor, to ask if we can then switch to an oral SERD that targets these ESR1 mutations at molecular progression prior to clinical progression, and what impact would that have on our patients. And there was a one-to-one randomization double-blind between continuing AI and CDK4/6 after detecting ESR1 mutations, or switching the endocrine therapy to camizestrant and continuing with the same CDK4/6 inhibitor. For the study, there was a large funnel to identify the patients with ESR1 mutations. So over 3,000 patients were screened in the study to identify the 315 who were randomized. And we saw really substantial efficacy for treating at molecular progression. So these are patients who have ESR1 mutations but have not clinically progressed. And we saw an over doubling of PFS and up to 16 months in the camizestrant group. But I think really what caught our eye from this study was the quality of life data and how you could substantially maintain quality of life longer by switching to camizestrant. And I think this really emphasized how much of an impact that first progression has on our patients' quality of life and the importance potentially of avoiding that by molecular surveillance for ESR1 mutations. And camizestrant in this study was really well tolerated. There are some people on camizestrant who get brief flashes of light in their peripheral vision called photopsia, but this doesn't impact their vision and generally, in my experience, tends to fade with time on drug. And just to highlight, we've got some updated data from SERENA-6. And then we've seen really important data from EMBER-3, which is looking at the addition of aluminescent, oronumenescent, and abemaciclib. We've seen data overall of clear evidence of ESR1 mutations, but a small subset of patients were relapsing on their endocrine therapy with ESR1 mutations. And in a subgroup analysis that is limited by small numbers at the top left there, we have got some evidence that in this particular setting, but really a subgroup analysis of the overall study. And then the studies that we're then also really waiting to look for are the first-line studies that are randomized from the start of first-line therapy between an AI and an oral SERD to ask if this is potentially the best way to use SERDs in the metastatic setting, possibly to prevent the tumor from developing an ESR1 mutation in the first place. So I hope we'll see the results of those studies next year.
Yeah.
And back to you, Komal.
Oh, no, thank you so much. I'm going to go with first names if that's okay with the panel. Is that okay? No, thank you so much for walking us through this data for endocrine sensitive and endocrine resistant tumors and what's coming next, which is obviously trying to see if, the SERDs can be utilized upfront instead of AI with a CDK4/6 partner based on Persevera and SERENA-4 and see how that will further impact our treatment paradigm. So why don't we go back to our first case? As a reminder, Helena was the patient who had de novo metastatic breast cancer, biopsy proven in the liver, ER positive, PR negative, HER2 low. She did have a comorbidity. Her baseline EKG had a QTCF of 450. Now, what first-line therapy would you recommend for this patient and why? Maybe, Nick, I'll ask you first. Do you have a preference? You've showed us the data with all 3 CDKs. What would you do here?
Yeah, well, I mean, it's very clear that I would give this patient an AI and a CDK4/6 inhibitor. I mean, we've seen the studies that have compared this approach to standard chemotherapy, and actually it's clear that giving this patient an AI and CDK4/6 inhibitor is better from the perspective of PFS, even in the presence of liver metastases, provided, of course, one isn't worried about impending visceral crisis. Personally, that a lot of people were influenced by the QTCF being slightly long. Personally, I still would give this person AI and ribociclib. Look at that 2-week EKG. Obviously, if you then saw further prolongation, I would then switch to another CDK4/6 inhibitor. But personally, I would have been comfortable to give this patient AI and ribociclib because for the vast majority of people, there'll be no change in their QTCF, and she would be able to go on my personal preferred first choice, which is to give letrozole and ribociclib.
Any additional thoughts here? Anything to add?
No, personally, please go.
In the setting of the borderline prolonged QT, for me, although like Nick, agree that I usually would be giving a patient AI and ribociclib first line, this is a case where I would use an alternative and pick abemaciclib. That way I don't need to worry about the QT prolongation being an excessive risk. But, we know that abemaciclib has its own side effect profile, and we'd want to counsel the patient about monitoring for diarrhea, early treatment of diarrhea, and making sure that they're ready for that.
Yeah. Giuseppe, add the thought.
So personally, this is a patient that should receive an AI plus a CDK4/6 inhibitor. The best one is Ribo, despite a QTC of 450 milliseconds. I don't believe this will be an issue if there is no prolongation, but for me, this is a patient candidate to AI and CDK4/6 inhibitor.
Right. So I think we have choices, and that's good. We can offer them ribociclib, we can offer them abemaciclib, we can monitor them. The side effects that we see are not necessarily very, with respect to QTC, that prevalent. What about the SERENA-6 strategy? I think that was exciting data that we can now think about intervening with molecular progression and not really have to wait for radiological progression. And certainly see how will that impact the data. You showed us impactful quality of life data. If the patient responded well to first-line treatment and had continued disease stability for 6 to 12 months, which is what the SERENA-6 patient eligible population was, would you actually start monitoring if you had that option available to this patient in clinic? Maybe, Nick, you can share your views.
Yeah, sure. So the short answer is yes, but I think there are a few things in the way. I mean, first, of course, we need the drug and the approach to be licensed. We also need cost-effective, highly sensitive ESR1 mutations to be available. So the test that was done in the clinical trial is likely not one that we could ultimately do in clinical practice because it would be too costly. And so we need to have widely available, relatively cheap, cost-effective assays for ESR1 mutations, which actually could then allow you to implement the surveillance at really minimal additional cost to the cost of the CDK4/6 inhibitor. And then you can do ESR1 monitoring every 3 months whilst the patient's in for their blood count cost effectively. My personal experience of patients in SERENA-6 is they really enjoyed that extra monitoring. Actually, they gave them a lot of reassurance. And then we've seen the quality of life benefit that you can get by switching to camizestrant and substantially deferring progression. So I think provided those things are in place, I think SERENA-6 is an approach we could really put into the clinic.
It was interesting that the median time to developing this ESR1 mutation was about 20 to 23 months, right? It took us a while to get there. And we know that in the first line, we're kind of talking about 25 to 28 months of median PFS. What are your thoughts about the serial monitoring from 6 to 12 months? Would you somehow modify that or think about monitoring maybe later on because the median time was that longer? Should we be thinking about it differently?
Well, half the patients in SERENA-6 were found to have an ESR1 mutation at time of first check, and 90% of patients who had an ESR1 mutation were identified within 5 ctDNA checks. So there probably is a sweet spot where we're going to have the highest yield of identifying these mutations. A patient who's been stable on their first-line AI and CDK for 7 years, the likelihood that they are going to be developing a mutation is going to be much lower. And so I think we'll have to think about who are the target patients. I also want to just agree completely with what Nick said about how patients felt about testing. Also, as an investigator on SERENA-6, I know that some have discussed there being kind of scanxiety with all of this serial ctDNA testing, and it was completely the opposite. Patients were really excited to learn more about their cancer, to have real-time molecular profiling, and they were, looking forward to getting results and using that in real time to make decisions. So I actually am thinking that, when this becomes available for us, that patients will welcome this as a treatment advance.
That's great. Thank you for sharing that. So now the case 2, which was Amy, who had endocrine-resistant disease because the disease had recurred within 12 months of completion of adjuvant aromatase inhibitors, has extensive visceral metastases, does not have germline mutations, and no other biomarker testing was conducted. A relatively high BMI, hyperlipidemia is managed, no other issues. So here, what would be the first treatment you would think about and why? Maybe Giuseppe, you could start with that one.
Well, this is a patient, I believe that, in my opinion, deserves also a molecular testing. So I would go for an NGS for sure, because this is a patient for whom I would consider eventually a combination of Inavo plus fulvestrant plus, of course, palbociclib. So this is the typical patient in which there is an endocrine resistance. You should check, in my opinion, for sure for PI3 kinase mutation. Absolutely. And if positive, the triplet combination would be my preferred treatment in this patient.
Okay, so let's assume she has the PI3K mutation. and we want to consider giving inavolisib to this patient. Are there any patient-related factors that we specifically want to look at baseline to see how they would tolerate this therapy? Erica, maybe you can comment?
Yeah, so in the Novel 120 study, there were fairly strict eligibility guidance about baseline hemoglobin A1C and lack of having diabetes. And although we don't see that for this patient, we definitely want to check her hemoglobin A1C. Her BMI is also on the high range for receiving inavolisib. There is, as we saw, a rate of hyperglycemia with the agent. And it is something that now that we know it's there, and if we know a patient is high risk, we really need to employ a very active monitoring and treatment strategy. For example, using a glucometer at home and having patients check their fasting blood sugar at least once every 3 days, if not more. Consideration of use of prophylactic or early administration of metformin to help with prevention or treatment of hyperglycemia, and that is on top of the routine monitoring we already are doing for palbociclib. So this is more clinically complex for us as providers in clinic to manage, but we do have all the tools available. I will also add, if we have our friendly endocrinologist who we can call, or diabetes nurse, that's been very helpful for us. But, as we saw, there are distinct advantages in this high-risk population, including an overall survival advantage. And so although this is a complex regimen, and for Amy, she is at risk of toxicity, this is worth trying for her. I would definitely want to offer this.
Yeah, no, I agree. I think, we all started off as oncologists being able to manage neutropenia very well, but now we have really expanded our skill set to managing diabetes and rash and stomatitis and ocular side effects and whatnot. So it's certainly, you brought up prophylactic metformin. When we think about these risk factors with high BMI or patients with diabetes, I think, or pre-diabetic range, I think it makes sense to think about what more can we do aggressively so we can offer these therapies and obtain the outcomes that the Inavo 120 regimen had. Let's make this a little more interesting. We didn't find a PIK3CA mutation, but surprisingly, we did find an ESR1 mutation. Nick, you pointed out that ESR1 mutations are subclonal. We see that with selective pressure of aromatase inhibitors and increases, as we use these agents in the metastatic setting. But say we have that 7% patient population that still can have ESR1 mutation at baseline, and we find that in this patient, you showed us a subset analysis with EMBER-3 that that patient population was included. Would an ESR1 mutation without a PI3K mutation make you think about that regimen if that was available in clinic today?
Well, I mean, the short answer, of course, it's not available in the clinic today because it's not been licensed by the FDA. I think, for me, I'm waiting for the results of the studies that have specifically looked at this question. So Persevera has specifically looked at, I don't mean Persevera, do I? Sorry, excuse me. Pioneera, thank you. Has specifically looking at this question of switching out fulvestrant for the oral STIR giredestrant, and they're enriching for ESR1 mutations. So we will have specific data in ESR1 mutant patients on whether an oral SERD is better than fulvestrant and a CDK4/6. For me, I think until we've got that fully powered data in that particular patient population that probably crops up around 10% of the time, I would still use fulvestrant and a CDK4/6 inhibitor, but I'm really looking forward to seeing that data, which actually I think could in the future change to using an oral SERD instead.
Yeah, that's a great point. I mean, we do have right now on the elacestrant and imlunestrant monotherapy available, and you have a first-line patient. Would you think about monotherapy at all? How would you think about ESR1 at this point? Or you would go with the fulvestrant CDK and an oral SERD after?
As Nick said, we don't have so many data to support a frontline treatment with imlunestrant plus abemaciclib. So if convincing data will be produced in the future for a patient like this, a next generation SERD plus a CDK4/6 inhibitor would be my option.
Right.
Or you may consider a clinical trial for a patient like this.
Yep, absolutely. Pioneera is still accruing patients. So yes, we can think about those kind of studies as well. So bottom line, I think we were trying to look at this endocrine-resistant patient population, a biomarker to see if what is the right strategy. Do we go with the doublet with the CDK? Do we think about the triplet? All right. And I think just wanted to give a shout out to this campaign, which I think is a very important that is available in our community. This is the metastatic breast cancer campaign which is called No One Is Missed. And this is, again, supported by Living Beyond Breast Cancer, our patient advocacy partner, which is launched in partnership with them. And it's a mission to really build public awareness of biomarker testing and empower patients to discuss testing and biomarkers with their healthcare team. I think despite having these approved therapies, we see that there is a big challenge with patients not necessarily having this testing, certainly more challenges in the diverse patient population as well, where I think it's even more limited, where they don't have this information. So I think tools like this, campaigns like this are very important for awareness so that you can ask your physicians, your care team about these testings and hopefully have those results and get those treatments based on those NGS results. It's a downloadable biomarker testing tool, so feel free to use the QR code for that as well. Okay, so we'll continue with Helena's case. And currently, she received a first-line CDK4/6 inhibitor, and she did get ribociclib. So, Nick and Giuseppe were thinking about this with ribociclib as well. She did have a good response. 23 months later, developed asymptomatic progression in the bone and new liver lesions. And ctDNA testing done at that time found an ESR1 mutation. There were no alterations in PI3K, AKT, or PTEN, and no germline BRCA1 or 2 mutations. So she now presents to your medical oncology clinic to discuss second-line treatment options. This is a scenario where Helena presents with disease progression on first line, but no targetable alterations were detected. So the previous case was with ESR1 mutation. Here there's no ESR1 or PI3K, and then she comes for a second-line treatment option discussion. So I think what we should do is have Dr. Mayer walk us through the data so that we know exactly what to do and why.
Thank you so much. All right, so now after a thorough coverage of the first-line setting, we're going to move on to talk about second line and beyond and how we take care of breast cancer beyond progression on CDK4/6 inhibitor with a focus on novel endocrine therapies. So, given our currently available or up until recently currently available regimens, this included drugs like aromatase inhibitor, tamoxifen, and fulvestrant. And although these have been tried and true regimens and agents that we've had since the 1970s, there are challenges with them. There are toxicity challenges, both in terms of side effects of the drug itself or method of administration, and particularly for oral agents, sometimes non-adherence is an issue, which is often driven by toxicity challenges. And fulvestrant as well, being an IM injection, has risks related to discomfort related with the injections, bioavailability concerns, and concerns about efficacy. And so it's time for us to have new therapies and more effective therapies for our patients. A survey that has been done through Living Beyond Breast Cancer has explored what oncology patients' preferences are. And this really stresses that patients prefer oral treatments to intramuscular or intravenous. I don't think this comes as a surprise to us. This makes total sense. But there are important features that patients point out that are important to them, such as the convenience of being able to take a medicine at home, not having risks of pain or being scared of needles, reduced burden for them to have to come into the clinic, gives people more of a sense of control, a feeling that they're actively fighting the cancer themselves, and perceptions of efficacy and safety. So many, many reasons why there's really great interest in trying to shift to oral-based regimens. Now, we are fortunate to have the development of multiple novel ER-targeting agents, which are currently either approved or in development, and this has been a very exciting space over the past few years. Let's just review what some of these agents are. So we have the SERDs, the selective estrogen receptor degraders, and there are 4 main agents in this category: elacestrant, imlunestrant, giredestrant, and camizestrant. There's PROTAC, which is proteolysis targeting chimera, and the lead agent is vepdegestrant. The CERAN is complete estrogen receptor antagonist, and the lead agent is palazestrant. And novel SERM, selective estrogen receptor modulator. Tamoxifen is our old SERM. Our new SERM is lasofoxifene. And all of these agents have been in active clinical trials. So let's first start talking about oral SERDs, and we're going to begin with the monotherapy studies, with the EMERALD study that looked at the agent elacestrant. This is the registration study that led to FDA approval of elacestrant in 2023. This was a study for patients who had had up to 2 prior lines of endocrine therapy for metastatic disease. All patients had had prior CDK4/6 inhibitor. Patients could have had up to 1 prior line of chemotherapy and were randomized to receive elacestrant monotherapy or standard of care endocrine therapy, which was provider choice. The study had co-primary endpoints looking at PFS in the ITT population as well as in the ESR1 mutant population. Now, this was a positive study, and it was particularly notable in the ESR1 mutant population where there was a significant prolongation in progression-free survival with a hazard ratio of about 0.5. Now, what was notable, and you can see this in the curves to the right, was that in the original Kaplan-Meier curves, there's a very steep drop-off in the beginning, and about half the patients have disease progression at time of first restaging. This suggests that there's a heterogeneous group of patients enrolled in the study, some who are endocrine resistant and some who are endocrine sensitive. And it's not until the endocrine resistant patients have left the study that we really see the true benefit of elacestrant in the endocrine sensitive population. And so a subgroup analysis, which is shown on the right, really highlights this for us, looking at patients whose cancers have the ESR1 mutation and have had at least 12 months of disease stability on their prior regimen. And here's where we see robust activity from the use of elacestrant with an improvement in PFS from about 2 months to over 8 months. And this is data which I think for those of us in clinic is highly informative and very much helps us identify best candidates for the agent. Just recently, we've now had 2 real-world publications that have looked at outcomes with elacestrant in real-world populations of patients. And I think this is super important because these are patients very much like who we're seeing in clinic every day, and this helps to very much solidify the activity seen in original trials. This is a analysis of 306 patients with a primary outcome of time to next treatment, looking at relevant subgroups, including those with 1 to 2 prior lines of endocrine plus minus CDK4/6, visceral metastases, co-mutations, no prior fulvestrant, no prior chemotherapy. And as we look across the board on the right for the time to next treatment, we see very robust numbers, all of them more than 6 months of disease control with elacestrant monotherapy. So very much confirming or even expanding the data that we saw from the original EMERALD trial. I'll point out in particular, I'm impressed with the no prior fulvestrant category with almost 13 months of PFS. Similarly, here's a real-world analysis. This is now looking at over 700 patients from the Garden Inform database, where we see a median time to next treatment of 6.4 months, and in patients who had had less than one or less prior line of therapy for metastatic disease, a time to next treatment of over 8 months. And dual mutations as well had a time to next treatment of 5 months. All of this very robust data that is both confirming and expanding our confidence in the EMERALD data and our use of elacestrant as monotherapy. I will also add that at this meeting, we're going to see updated data from an important study called ELEVATE, which is looking at elacestrant combinations. So combining elacestrant with a targeted partner, which is demonstrating to us even more robust activity when you combine an oral SERD with a targeted agent. And this is a theme that we're going to see in the subsequent trials. Now let's move on to EMBER-3, which we already spoke about before, considering the role of this regimen in the first-line setting. But instead, let's look at the primary endpoints of this study, which was designed to look at comparisons as monotherapy between imlunestrant, an oral SERD, and standard of care endocrine therapy in the intention to treat population, the ESR1 mutant population, and also considering the combination of IMLU and abema versus IMLU alone. Here are the monotherapy comparisons, and we can see that here the strongest signal is in the ESR1 mutant population, somewhat similar to the EMERALD study, with an improvement from 3.8 months to 5.5 months. And this is the data that has led to the very recent approval, as we mentioned, of imlunestrant monotherapy. So now 2 oral SERDs available as monotherapy in pretreated patients. And then we have another monotherapy study, this one using the PROTAC vepdegestrant, a quite similar design of pretreated patients, all of whom had had prior CDK4/6 inhibitor, no prior chemotherapy in this study, randomized to receive vepdegestrant monotherapy or fulvestrant monotherapy. And again, we see the same signal that the benefit of these novel endocrine agents as monotherapy is in the patients who have ESR1 mutations, who have a resistance mutation, with an improvement from 2 months to 5 months that was not seen in the ITT population. Now, how about the safety of these drugs? Well, I think we're all really delighted to see that oral SERDs are extraordinarily well-tolerated endocrine agents. This is looking at all-grade toxicity across the monotherapy studies, including also camizestrant, and shows that overall with the We see some mild GI toxicity such as nausea, I'd say rare vomiting, but in general, these are really very well tolerated drugs. And in terms of grade 3-4 toxicity, this is exceedingly rare. We did point out that there are some toxicities of oral SERDs that are a little bit unique to the class, including the photopsia that we mentioned, and some of the oral SERDs can cause very mild bradycardia, which does not require intervention, but it is something that a patient might experience when they come to clinic and they have their vital signs checked. But is this the best way to be giving an oral SERD? And is a combination better? And perhaps this is the next step forward for us to really maximize the benefits that we see with this class of drugs. We do know that there is extensive crosstalk among the signaling pathways in cancer cells, including the PIK3CA, the cell cycles CDK4/6, and ER signaling pathways. And it is possible, or likely probable, that co-targeting of these pathways with rational combinations is the best step forward. So let's look at some of the data for this. So again, we'll return to EMBER-3. Now we're going to look at the combination arm, and this is imlunestrant and abemaciclib versus imlunestrant alone. And here we see an improvement from 5.5 months to 9.4 months. So again, breaking the 6-month barrier in the post-CDK space. And importantly, this benefit was seen in the population of patients whose cancers had an ESR1 mutation and in those who did not have an ESR1 mutation in this exploratory subgroup analysis. And we can see the median PFS in the ESR1 mutant population is now 11.1 months. So very robust data. And additionally, a subgroup analysis has been done in the ITT population versus the 60% of patients who had prior CDK4/6 inhibitor, also showing that this benefit is consistent in the CDK4/6 pretreated population. The safety data from EMBER-3 overall has been very favorable, and similar to many of the studies that have looked at combinations, that if you look on the right for the combination arm, the vast majority of toxicities that are seen reflect the targeted partner. Here we see diarrhea, a very classic side effect related to abemaciclib. But importantly, when we think about discontinuations at the bottom, discontinuations due to adverse events with these endocrine agents are extremely low. So again, an extremely well-tolerated category of drugs. Additionally, and importantly, injection site reactions were obviously more in the standard of care where patients were getting an injectable endocrine therapy. And we will be seeing an update from Kamal herself later on this week on Friday at General Session 3, showing updated data from the EMBER-3 study, now at a median follow-up of 28 months, a clinically meaningful improvement in overall survival seen with imlunestrant versus standard of care endocrine therapy in the ESR1 mutant population. So I think that's going to be very exciting and very important to solidify our confidence in this data. Now let's move to our second combination phase 3 trial, which is the AVERA study, which was presented at ESMO this year. And now this is using the oral SERD giredestrant. The study population is similar to some of the other trials, up to 2 prior lines of endocrine therapy. All patients had prior CDK4/6 inhibitor, no prior chemotherapy, and patients were randomized to receive a combination in either arm. So giredestrant and plus the mTOR inhibitor everolimus, or standard of care endocrine therapy and everolimus. So this is the first oral SERD study that is looking at combination versus combination. This is not a study putting a combination versus, let's say, fulvestrant, which we have repeatedly seen as monotherapy performs poorly. Here we're using a comparator arm, which is a fairly modern combination, something that many of us are using in clinic routinely, and I think provides a nice contemporary balance. There are co-primary endpoints in this study of progression-free survival in the ESR1 mutant population and in the ITT population. So this was a positive study. Patients who received giredestrant had a prolongation to almost 10 months in the ESR1 mutant population and 8.8 months in the ITT population. I will add there was an exploratory subgroup analysis in the what's called no mutation detected population where there was no significant difference in the PFS. However, there is a favorable trend for overall survival and improvements in response rate and duration of response in the no mutation detected group. Similar to what we've seen before, giredestrant was extremely well tolerated in this trial. There was very few endocrine-related side effects, and there was no substantial imbalance between the arms related to endocrine side effects. Additionally, discontinuation of endocrine therapy was quite low in both arms. This is the tornado plot from Avera, and we don't often see tornado plots actually looking like tornadoes, but this one does because it's so symmetric. This is because there is no substantial difference in toxicity between giredestrant versus standard of care endocrine therapy. The vast majority of toxicity seen here, stomatitis, diarrhea, nausea, these are all related to everolimus, not to the oral SERD. There were a few cases of grade 1 bradycardia, which did not require any intervention or other difficulty. And there will be an updated report from Avera specifically looking at pre-specified subgroups, including patients with PIK3CA mutations, PAM pathway mutations, and outcomes depending on duration of prior CDK4/6 inhibitor. This will also be in General Session 3 on Friday. We also saw at ESMO this year first results from the Victoria-1 study. Victoria-1 is designed to study a new agent, gedatolisib, which is what's called a PAM inhibitor. It targets PI3 kinase and it targets mTOR, so it targets the whole pathway. And this is a study that has a somewhat complex design, but it has two parts. Study 1, which is what was reported, was for patients who are PIK3CA wild type. Study 2, which is for PIK3CA mutant patients, it will be presented in the future. But for study 1, patients were randomized to receive a triplet of gedatolisib, palbociclib, and fulvestrant, a doublet, gedatolisib, fulvestrant, or fulvestrant monotherapy. Now, I will point out that what makes gedatolisib a little bit different than other agents is that this is actually intravenous. It's once a week IV treatment, given 3 weeks on, 1 week off. It's not chemotherapy, even though that schedule may seem reminiscent of chemotherapy. It's a targeted pathway inhibitor. And we saw that for the endpoints of the comparison of the doublet versus fulvestrant monotherapy or the triplet versus fulvestrant monotherapy, these were both strikingly positive with prolonged progression-free survival beyond 6 months in both comparisons. I will also point out we continue to see poor activity of fulvestrant monotherapy, which is a reason why we would all discourage use of this in clinic, of the fulvestrant. The gedatolisib does have a side effect profile which may be reminiscent of other mTOR type inhibitors, including about 70% of patients having grade 3 or any grade stomatitis, about 20% with grade 3 stomatitis. Reassuringly, however, discontinuations in this study were very low. It was only about 2.5% to 3% of patients had to discontinue therapy due to side effects. There are other ongoing studies which are looking at novel combinations. This includes the ADELA study, which is looking at the combination of elacestrant with the mTOR inhibitor everolimus, and the Pioneera study, which is for pretreated patients randomizing to giredestrant and CDK versus fulvestrant and CDK. And so I'll pass it back to you.
Thank you so much. That was a tour de force in the second line setting with so much data. We have actually a lot of interesting questions that have come through here as well. And I was thinking, time is really flying and we don't have a lot of time. But why don't we do like a rapid fire, just quick answers for some of these questions so that we can continue talking. So how effective do you think these oral SERDs or these combination therapies can be in patients with visceral metastases or high disease burden? Do we think they would work there?
Subgroup analysis from the combination studies has shown consistent benefit with the use of the SERD and targeted combinations in patients with liver metastases, visceral disease, bone-only disease. It's been difficult to identify a subgroup who's not getting benefit from these regimens.
Thank you. Nick, do you think there is a trick to identifying patients at risk for endocrine resistance? It's a tricky one.
Yeah, I don't think I quite know what the answer to the question is.
Yeah.
I mean, we know a lot of routine factors. ESR1 mutations likely to be more endocrine sensitive when you use a SERD. You know, lower burden of disease, longer time on their prior AI and CDK4/6 inhibitors.
So essentially some clinical
point towards
factors.
or likely to benefit.
Yeah, so we don't have any other magical markers other than what we have learned with clinical factors. Giuseppe, maybe you could address this. You know, we talked about ribociclib as our choice in the first line setting. And then Nick talked to us about Persevera and Serena-4 that are going to read out, but they have palbociclib as a backbone CDK4/6 inhibitor, and then Opera 2 with palazestrant, the CERAN, is with ribociclib. So when these data sets are reading out, how would you be thinking about palbociclib being the CDK versus, say, palazestrant with ribo? Does that make a difference, or how do you think about this?
We cannot extrapolate from clinical trial, so I would use the combination of the registration trial, of course. So you cannot extrapolate on this because you don't have the data to support an extrapolation.
Absolutely, absolutely. But say if all three were positive, I guess, do we think about one study more applicable to patients in clinic? Would it matter, or we'll have to just review the data to decide?
What is happening now, just to do a comment first, the first one is that in all this clinical trial that we are doing, the comparator arm is not the standard of care because everything is so rapidly evolving. So in order to validate some data of this registration trial, maybe you need some pragmatic real-world trial to assess effectiveness in the real world. And the second point that is almost important, in my opinion, is that in the majority of the cases, we are writing guidelines based on the inclusion criteria of the studies. So anytime you have a new patient population, you add a line for a specific subgroup of patients. So what we see in the second line, that is a biomarker-driven approach, is more based on the registration pathway of any single agent. And this is something that we should reflect on.
Absolutely. Absolutely. Thank you for that. Do we think these treatments work equally with lobular disease? Do we have a reason to believe that it would
yes, absolutely yes. Even if there is a difference maybe in the molecular profile of lobular cancer, but yes, they fit. Yes.
Okay, thank you. All right, let's keep doing. I think great questions. Keep them coming. We'll try and address as many as we can. So we're going back to Helena, who had ESR1 mutation in the second-line metastatic setting. How do we think about, among the oral SERD monotherapy or SERD combinations, how would we think about utilizing if we had all of them available, Erica? Is there a way for you to break down when would you think mono, when would you think doublet? And if you were thinking doublet, which targeted combination partner?
Yeah, so I'm a believer that we're moving towards doublets as being the preferred standard of care. And so, in a future point in time when hopefully we have multiple options available, combining oral SERD and a targeted partner, that would be my preferred choice. This particular patient, having had 23 months of prior disease stability on first-line AI and CDK4/6 inhibitor, is a good candidate right now for oral SERD monotherapy using one of the approved agents. And I do think there will always be a population of people for whom that is a nice choice. And again, these are well-tolerated drugs, and with the right patient, we know we can achieve a prolonged period of disease control. But I do think that ultimately moving towards the combinations will be important. And as of which combination to pick, some of that may depend on the side effect profile, the patient preferences, comorbidities, doctor and patient comfort with managing the side effects. So I think those will become very patient-specific decisions.
Very clear. Thank you so much for that. Moving on to the case where there were no alterations seen. So in the second-line setting, we saw nothing in terms of a targetable alteration. What kind of factors would you then consider for treatment selection if you don't have a targetable alteration? What's your trick, Nick, in clinic if you don't have any other biomarker?
Well, I think it's the same as what we've just discussed. I mean, this is the kind of person where you might think if you're using fulvestrant and everolimus, if you want to use a endocrine-based option, very much agreeing with Erica that I don't think for the vast majority of people, single-agent fulvestrant is an appropriate option. Off-label, you might want to use fulvestrant and abemaciclib here as another potential option. But for people who had shorter duration of time on their previous therapy with a high burden of liver metastases, in this patient population, I would also consider chemotherapy or an ADC as an option for them.
And does the kind of CDK4/6 palbo, ribo, or abema influence your decision about what you would do in the second line as a combination?
Well, as in what they had in the first line setting. I think yes. We think that we don't really know the answer to the question, but if we look at studies like PACE, where you maintained the same CDK4/6 inhibitor, you didn't appear to see substantial amounts of benefit continuing the CDK4/6 inhibitor, whereas if you look at switching, say, to abemaciclib, you appear to see more substantial benefit. So I think it does matter a lot, and it appears to be that when you switch to abemaciclib, you see some efficacy, but we do need to remind ourselves there is not a license for the use of it in that indication.
Does it matter if you found a P53 mutation, but it was an ESR1 wild type? Would you feel like you would choose one particular therapy is a question?
Yeah. I don't know if sorry, I should let them. But the answer is probably yes, actually. I mean, P53 mutations clearly associate with relative endocrine resistance.
Yes.
But we have, so I think it likely would influence your data here. But of course, it's not something that we use routinely in the clinic. But sorry.
What if you find a retinoblastoma mutation?
Loss of RB would be a clear signal not to give continued CDK4/6 inhibitor.
It was interesting.
This is very important information for the audience because as we have biomarker predicting of activity, also of retinoblastoma is a clear biomarker of no response to CDK4/6 inhibitor.
We've seen some interesting biomarker analyses from the Emerald trial where they looked at different alterations, including P53 mutations. And there we did not see in that subgroup analysis. It was quite interesting. Again, it's a subgroup of a subgroup. We're looking at the duration of prior CDK, we're looking at the alterations, and we're seeing. But it was interesting that even in the P53 mutant subgroup, the benefit was seen with oral SERD. But yeah, I would agree. Otherwise, we're thinking about P53 as a marker of resistance. There you go. We have Amy here. And Amy started on fulvestrant CDK4/6 and maintained stable. So this was an endocrine-resistant patient who was treated with fulvestrant and CDK, and before developing clinical and radiographic progression at 10 months. So she was stable disease, 10 months. Biomarker testing now shows a PI3K mutation and an acquired ESR1 mutation, both. How would you treat this patient in the second-line setting after 10 months of fulvestrant CDK with dual mutations? All right, Dr. Corigliano, talk us through the second-line options.
Let's try to see the data of this patient population. So, as you know perfectly, actually, PI3 kinase and AKT are a mechanism of resistance in ER-positive disease. Since almost 20 years, we worked specifically on targeting this pathway, including also mTOR. The first trial to have as an inclusion criteria the pathway of PI3 kinase, AKT, and PTEN was exactly the Capitello 291. This was a prospective randomized trial including men and pre- and postmenopausal women with a recurrence on or within 12 months from the end of adjuvant AI or PD on a prior AI in an advanced breast cancer setting, less than 2 lines of endocrine therapy, no prior SERD. Of course, patients have been randomized to capivasertib plus fulvestrant versus placebo fulvestrant. And the dual primary endpoint was the median progression-free survival investigator assessed in those with the AKT-altered pathway and the intent to treat population. The key secondary endpoint was overall survival and overall response rate. A stratification factor have been considered liver mets, yes or no, prior CDK4/6 inhibitor, because not all of them received prior CDK4/6 inhibitor and region. The trial demonstrated an improvement in investigator-assessed median progression-free survival, improving median PFS from 3.6 months to 7.2 months in the overall population, but the combination got an approval in AKT-altered pathway. So actually the combination of capivasertib and fulvestrant is based exactly on this data in the AKT pathway altered population. So when you do a biomarker testing, you should test for PI3 kinase, for AKT, and for PTEN, so you will have a probability to check. We will have new data here during San Antonio. So we have in the rapid fire session, of course, some data on exploratory ctDNA analysis. And of course, what we will see here is that ctDNA analysis may offer a minimal invasive option to identify PI3 kinase, AKT1, and PTEN alterations in HR-positive advanced breast cancer, specifically for those patients who may not have access, of course, to a biopsy. Not all the time a tissue biopsy can be feasible. So the second study, of course, in this setting, PI3 kinase mutant, is the SOLAR-1. This was a prospective, biomarker-driven, randomized trial comparing fulvestrant plus alpelisib versus alpelisib plus fulvestrant. And in the clinical trial, the SOLAR-1 demonstrated the improvement in median progression-free survival, specifically in the cohort with PI3 kinase mutation with no benefit on overall survival. No patient in the SOLAR-1 was included with the previous CDK4/6 inhibitor. That's why the BILIV trial was completed under request of FDA and EMA. And in the BILIV trial, the median PFS in the PI3 kinase mutant population after CDK4/6 inhibitors is 7 months. So it's a good result. So this is an option that can be considered, of course, pending assessment and management of all the toxicities. We will have this study. This was a study explicitly required by EMA, randomization to alpelisib plus fulvestrant versus fulvestrant plus placebo in the post-CDK4/6 inhibitor setting, the ACPE 05. The primary endpoint was median progression-free survival. We know that there is a median PFS improvement, and there is also a positive trend for overall survival. We will see this data during San Antonio in a mini oral session. What's about other option? This is an option that has been based on a single-arm study in France combining fulvestrant and everolimus, in which there was, of course, a benefit in the previous study without a previous exposure to CDK4/6 inhibitor, and now we have this data also after CDK4/6 inhibitor with the median progression-free survival of 6.8 months. If we move now to sequential use of alpelisib and everolimus, this is an important question. So if you receive the INAVO in the first line, are you going to give capivasertib in the second line? Or if you received alpelisib before, are you going to give everolimus in the later line? And this is a multivariate model adjusting for prior CDK4/6 inhibitor and prior lines of therapy that they have been recently submitted and is impressed in breast cancer research. And finally, the sequential use of alpelisib and everolimus, one targeting PI3 kinase alpha selective, the other one the mTOR pathway, in a multivariate model, TTF1 and TTF2 were not significantly different between groups. And here we can see the data of sequential use of alpelisib and everolimus. Usually, of course, TTF1 generally is longer than TTF1, TTF2, because there may be a cross-resistance, of course, in the two pathway. In the EMBER-3 has been investigated, of course, the benefit of imlunestrant plus abemaciclib in the patient population with both mutations. That was exactly the clinical case we discussed. Here we have patients with concurrent ESR1 mutation, MPI3 kinase mutation. It's a very limited number. You can check here, very few numbers, but it seems that the combination can be beneficial if you have both the alteration. I must confess also in the EMERALD trial was performed a similar analysis, and finally the median progression-free survival was 5 months, so exactly the same benefit, and also in the Capitello trial there was a similar subgroup analysis. Other select phase 3 ongoing trial are the Victoria-1, finally, in which we have the exploration of the activity in the subgroup of patients with PI3 kinase mutation, and the INAVO 121, INAVO plus fulvestrant versus alpelisib fulvestrant in pretreated patients, HR positive, HER2 negative, with PI3 kinase mutation. So now we go back to the clinical case, remembering that in both mutation, all the options potentially can give the same benefit in terms of median progression-free survival.
Yeah, absolutely. Thank you so much for walking us through this. One question that has come up here is that in the post-CDK subgroup analyses from the Capitella 291, the median PFS was 5.5 months.
Correct.
And how do we think about that data when we think about utilizing, say, alpelisib or capivasertib in clinic with respect to that efficacy?
We have more data in this case for capivasertib, and I would consider, rather than alpelisib, capivasertib as a combination in its patient population, unless in the EPIC-B05 they will not provide more data in a subgroup analysis.
And is that based on safety that you feel it's not the efficacy that is necessarily what is driving this? It's
but in a patient population like this, I would consider also the safety profile personally, because we are in the second line setting. We know that you cannot move before 7 months in this patient population, so safety can be an issue, of course.
Okay, so as you pointed out, this is the case that had both dual ESR1 and PIK3CA mutations after first-line fulvestrant and CDK. What would you offer this patient specifically in the second-line setting? Any thoughts, Nick? What would you give?
For the bottom question, if they progressed on the triplets, Kamal, or this is somewhere where we really need more data. I mean, certainly we even need to see the data from Inavo 120 and time on second-line therapy. So if they've got an ESR1 mutation, I think this is somewhere where I would like to see using a combination of an oral SERD and a targeted therapy in this setting. We've seen that there's not clear cost resistance between an mTOR inhibitor and a PI3 kinase inhibitor. So provided the patient fits into that potentially endocrine sensitive characteristics we were discussing earlier, I think there would be a role for using an oral SERD, which would be giredestrant and everolimus, for someone like this, more aggressive progression. And I think I would be thinking about chemotherapy in that particular setting.
Yeah, no, completely makes sense. I think you pointed out that, one, this is a data-free zone. We still need more definitive randomized data. But I think some signals, at least we've got analyses from the Emerald subgroup as well, where patients with dual mutations still had 5.45 months with elacestrant monotherapy. We saw subgroup analyses from post-Monarch with fulvestrant abemaciclib, and benefit was seen regardless of ESR1 and PI3K, which was interesting. In EMBER-3, when we looked at double alterations and we looked at the combination of imlunestrant and abema, the median PFS was 12 months, which was interesting as well. We'll hear about subgroup analyses from Ivera from Hope Rugo on Friday, and Nick will put all those data into perspective again on Friday for us. So do join us in that oral general session on Friday.
And I think another reason why I like the approach of using the oral SERD as my preferred agent, we've written here that she has poorly controlled type 2 diabetes. All of our agents targeting PI3 kinase or PAM pathway have risks of hyperglycemia. So by selecting the oral SERD regimen first, that gives us some time to work on managing that. And, looping in our endocrinologist, helping, work with the patient to get the diabetes under control. So she's a good candidate to get potentially PI3 kinase pathway targeting agent as a subsequent line of therapy, if not moving to chemotherapy.
And talking about toxicity profiles, I guess, and safety, as Giuseppe pointed out, is very important to him. We've seen relatively less hyperglycemia, say, with capivasertib than we've seen with PI3K inhibitors. And so if it was just going to, this dual targeted therapy, I think fulvestrant capivasertib from that perspective could also be considered. So more to still see how do we treat patients post the Inavo 120 regimen in the second line setting, but certainly if appropriate for endocrine therapy, we can offer them an oral SERD with ESR1 mutation or a combination, or chemotherapy if not an endocrine candidate. And so resolving these open questions and areas of uncertainty and preparing for real-world practice, I think that's what we need to do. And
this is an area of uncertainty because all the clinical trial does not match exactly for this clinical case.
Right.
That's why I believe there is a lot of confusion in the selection. Any answer can be the right answer.
Yes, no, absolutely. And, You mentioned the two trials, INAVO 121 and there's INAVO 123. We're trying to see if the INAVO 20-like regimen would be appropriate even in an endocrine-sensitive setting in the frontline setting. So with AI as a backbone partner, we'll see what happens with approaches like that. We have Capitello 292 with CAPI in a triplet regimen as well. So a lot happening and a lot for us to unpack and unfold eventually. But just to kind of think about the data sets that we reviewed today, including in the second-line setting, we had monotherapy data from Emerald. We have monotherapy data with camizestrant from the phase 2 SERENA-2 trial. We heard about the EMBER-3 study. We looked at Capitello 291. There was a study presented at ASCO this year with ipatasertib, which was another AKT inhibitor. We heard about Evera, and we also heard about Victoria. What is really evident from all of these trials is that when we think about combinations, perhaps we're able to, move that needle of progression-free survival, which was hovering around the 6-month range or under 6-month range, to slightly better or longer PFS benefit with combinations. And so, it's possible that we might be able to achieve that better with doublets and potentially triplet strategies. So we had started off with our treatment algorithm when we started this session, and we're ending kind of where we might land. I think the ones in the greens are potentially the approvals, depending on what the regulatory agencies review and do, of course, that might change our treatment paradigm again. So we were talking about AI-CDK to be the majority of our patient population. We heard from Dr. Turner about SERENA-6, and if that were to become possible, and we might have a good biomarker to do this serial testing, it's possible that we might want to do that, have a good discussion with our patients if that's appropriate for them, talking about the quality of life data that we have. We don't have overall survival data from that study yet, so I'm not sure if it's necessarily going to be for all patients. I'm going to do that for all, but it might be very appropriate to have a discussion with the patient and talk to them about what's important to them based on the data that's available. For our endocrine resistance setting, again, with the PIK3CA mutations, we have the INAVO regimen, or we have fulvestrant CDK. Upon disease progression with ESR1 mutations, we had monotherapy approvals. We might have more monotherapy PROTAC approval potentially for vepdegestrant. We'll see what happens with imlunestrant, abemaciclib, and giredestrant everolimus, but we saw the data for those in ESR1 mutant patients as well. For PIK3CA alterations, we spoke about capivasertib and alpelisib with fulvestrant. We saw some subgroup analyses for imlunestrant and abema. We will hear more subgroup analyses for giredestrant, evero, and we'll see. But in general, we think about everolimus not being necessarily a biomarker or being, not requiring PI3K mutation as a biomarker necessarily. And for wild-type patients, again, we had the post-monarch regimen. We have evero plus fulvestrant monotherapy, and potentially, depending on how these readouts are reviewed by the regulatory agencies, they might potentially join the treatment paradigm. A couple more questions as we have a few more minutes. We can talk about...
Kamal has a gentleman who's got his hand up.
Yes. Oh, I would love
a live question. Yes.
Okay. Yeah. If you fail the CDK, you want it. You're saying doublet is better, but if you fail the CDK, are you really benefiting from switching CDKs? Wouldn't you be better off not using a CDK and using a doublet with different mechanisms?
Yes, of course. This is the concept finally. So if you are going to use a giredestrant plus everolimus, of course, in the second line, you can achieve a better result, specifically in ESR1 mutant. But if you don't have any alteration, ESR1, PI3 kinase, mTOR, something else, you should go, if indicated, because of course it would be your choice if to give a second-line endocrine therapy, you will go for specifically for another endocrine therapy plus another CDK4/6 inhibitor.
So I think, when we were talking about the EMBER-3 subgroup analyses, we looked at the analyses by ESR1 mutation status in that subgroup. So those patients who received imlunestrant plus abemaciclib and tumors had ESR1 mutation, the median PFS for the combination was 11.1 months compared to 5.5 months with imlunestrant alone. When we looked at the giredestrant and everolimus data, again, in the ESR1 mutant population, we're still seeing north of 10 months as median PFS. So it seems like with combinations, we're able to achieve more than what we were able to achieve with potentially single-agent therapy. Certainly, single-agent was very effective if you had a good endocrine sensitive tumor, long duration, and ESR1 mutation, but seems like combinations might be appropriate. Your question is, how would you then decide which targeted therapy combination to go for? I think you have choices. You have side effect profiles. Hopefully they're both available. We don't have that available today in clinic, but if they are, you have the side effect profiles to think about. You have the choices to discuss that with your patient population. Efficacy seems very interesting, and you can choose one based on that discussion. Are there better predictors for oral SERD combinations compared to monotherapy? Are there any predictive factors we could go after?
I mean, in the studies that have looked at the combinations, including EMBER-3 and Avera, when looking at subgroup analyses, consistently all of the subgroups, all the clinical pathologic subgroups, are benefiting from the use of the oral SERD combination over a standard of care endocrine combination. So to date, we don't necessarily have a factor arguing for or against, although we, importantly want to consider all of our molecular markers as well.
Nick, do you think there is a role for oral SERDs and novel therapies in patients with no ESR1 mutations today?
Well, I think we can wait for the answer to that question tomorrow when we see a data from lidERA in the adjuvant setting, at which point I think we know already from the press release the answer will be yes in the adjuvant setting. In the second line setting, though, I think my personal answer to that question is no. I think we're clearly across all of the studies are only seeing improvement in efficacy in the ESR1 mutants. We're not seeing an improvement in efficacy in the ESR1 wild type over standard of care endocrine therapy.
Okay, thank you.
The question, though, is what about the first-line studies and what will we see there?
Yeah.
So we still definitely have the potential to see efficacy in the studies that are looking at AI CDK4/6 versus SERD CDK4/6. I think that might be a setting where we could well see efficacy of SERDs in the wild-type patient population when we're getting into a much more endocrine-sensitive patient population. But, that's speculation. We need the readouts of those studies, which should hopefully come next year.
So TBD on that question a little bit until we have the readouts on the first-line studies, but certainly excited about the adjuvant studies. Maybe one more question here, Erica. How do patient-reported outcomes support clinical use of oral SERD and novel combination? Do you think that that's a strategy that would help support our clinical use of it?
Well, I think the most provocative PRO data that we have comes from SERENA-6, where we see that patients who switch to camizestrant at time of emergence of an ESR1 mutation during first-line therapy had a substantial delay to deterioration in not only global quality of life, but also the patient reported symptoms of disease progression, including pain, fatigue, shortness of breath, and also patient functioning, how well they could work or take care of their families and their emotional functioning. So I do think that that's a very powerful statement supporting the SERENA-6 approach. Capturing PROs as part of clinical trials of novel therapies is so important because we do know that there's a gap between what is written as CTCAE toxicity that's reported by the clinical team versus what a patient is actually reporting in their own voice. And so it's always important to look at this when we're studying new agents.
Yeah, thank you. And last question online is...
There's a question in the audience.
There is a question in the audience. Yes, thank you.
Hi, question on biomarkers. As I think that there was a previous chart talking about ctDNA-based testing that's going to become more and more important for this ESR1 category, and also for the PI3K as well. My question was, and Nick, you showed a slide that had a bar chart with the concordance of ctDNA versus tissue. And I believe the third column, the concordance was pretty bad, the ESR1 between tissue and ctDNA. There was a lack of, maybe I misread the chart, but that's a known fact that ctDNA tends to miss a lot of these mutations. So I'm wondering, how do you make sense of that, particularly when ctDNA is going to become more and more important going forward for this in the second line category? And also, there's more and more evidence that was presented at ESMO that looking at CTCs in combination with ctDNA increases the concordance and gives you a much more accurate view of the actual mutations, because you're kind of looking at fragments when you look at ctDNA and you're looking at it in bulk. So you tend to miss a lot of the emerging resistance mutations, so to speak. So.
Yes, so we didn't have time to go through that data, but actually it shows the reverse to what you said, which is you see more ESR1 mutations in ctDNA analysis than you do in contemporary biopsies. And actually that's the key piece of data that graph showed that we, didn't have time to go through in detail. And so that's what's then led to the general advice that testing specifically for ESR1 mutations is preferred to be done in liquid biopsies. There is, of course, the other setting generally for liquid biopsies that if your tumor's not shedding, you might miss the mutation and you might need to do reflex testing, which is the general point you brought up.
So this is just talking about adjuvant SERT trials. This table really summarizing all the various strategies, whether it's a switch strategy after endocrine therapy for a few years up front, whether it is combining it with the CDK in Cambria-2, and we spoke about lidERA, which is going to be presented tomorrow at the general session, and Dr. Lisa Carey is going to do a nice discussion after Dr. Bardia presents this results. So very exciting times. So I really wanted to thank everyone for their engagement today, for the interactions, for these very interesting discussions, and first and foremost, a big thank you to our huge panel here for going over this data and breaking it down for us. It's a lot complicated and a lot more heterogeneous. To treat ER-positive breast cancer is not as easy, this most common subtype, but I think it was very helpful to understand your perspective, and thank you for walking us through the data. And thanks again to Living Beyond Breast Cancer, our patient advocacy partners, and what they do for us in clinic for our patients.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, Living Beyond Breast Cancer. This activity is supported by independent educational grants from AstraZeneca, Genentech, a member of the Roche Group, Lilly, and Stemline Therapeutics, a Menarini Company group. To access all materials for this activity, visit peerview.com/NXT860.